Good morning, everyone. Thank you, everyone, for having me here today, and especially thank you, Dr. Krishnan, Ray, Beth Oliver, and Liz Emerichu for having me. My name is Shiva. I'm one of the nurses at Mount Sinai Hospital, and I'm a cath lab nurse. I'll be discussing the prevention of contrast-induced nephropathy utilizing the Dr. Moran score. I have no financial relationships. So what is contrast-induced acute kidney injury? It's defined as the acute onset of renal injury following exposure to iodinated contrast media. Now, although this sounds simple enough, there has been a lot of controversy over this definition. Some radiologists question, how do we know for certain the kidney damage is due to the contrast received rather than the medication the patients are on or new hypotension or heart failure, for example? Creatinine levels will peak at about 3 to 5 days after administration of contrast, but typically return to or near baseline levels within 1 to 3 weeks. So to define it even more in detail, these are the current definitions and classifications that nephrologists use. As you can see, they are all very similar, but stage 1 is a creatinine 1.5 to 2 times the baseline, and stage 2 is creatinine 2 to 3 times the baseline, and stage 3 is 3 times the baseline. You will also be looking at the urine output for all 3 stages. I think one of the most commonly used definitions of these 3 is the KDIGO, which is the one all the way to the right, but all are very similar in their definitions. So now let's look at the mechanisms behind how this occurs. There is both direct and indirect damage that can cause a kidney injury. When contrast is delivered, there are direct toxic effects on the tubular cells. This is called osmotic nephrosis. When considering the indirect effects, the main takeaway is that the contrast induces vasoconstriction. There is a lot more that goes on in the cellular level, but this vasoconstriction in turn reduces the glomerular blood flow and oxygen delivery. So contrast-induced kidney injury is one of the most frequent complications after an endovascular procedure, and now is the 3rd leading cause of AKI in hospitalized patients. Now, the incidence of cardiac contrast-induced AKI in patients post-interventions varies between 0 to 24%, but this is because the tubules can regenerate and creatinine levels can return to baseline. But for some patients, they are not so lucky, and dependent on certain risk factors or the urgency of the cath, being an ischemic limb or endovascular complication, there is a higher incidence of injury. And lastly, this development of AKI has been associated with worse outcomes, the increased hospital stay and cost, irreversible kidney injury, need for dialysis, and even death. So how do we prevent this from occurring? As you can see from this illustration, there are pre, intra, and post-procedural interventions we can perform. For example, hydrating the patient, reduce the contrast volume, inject it to a minimum, and use iso or low osmolarity contrast agents. However, if you ask Dr. Moran, she will tell you there are 3 simplified things that can make the biggest impact, and these are identifying high-risk patients, hydration, and minimizing contrast use. So now we will talk about each of these important factors. First off, when it comes to identifying high-risk patients, this is when the risk score comes to play. The Moran grading scale, which was introduced in 2004, includes 8 risk factors that, when tallied up, will give a total score to predict the estimated risk score for the contrast-induced nephropathy. And I'm sure a lot of these make sense to you. With the heart failure patient, you know you get renal congestion. And with the diabetic patient, a lot of them already have diabetic nephropathy. And the uncontrolled hyperglycemia doesn't help. However, Dr. Moran felt that the risk score needed to be updated as it is almost 20 years old, and patient profiles have changed. The research she, Dr. Krishnan, Dr. Kinney, and Dr. Sharma, and other physicians performed at Mount Sinai Hospital was published in The Lancet just this past November in 2021, as you can see above. This is a huge honor. So the study population for the new and recalibrated risk scores was designed based on patients who had a PCI at Mount Sinai Hospital from 2012 to 2020. and had available creatinine measures both before and within 48 hours after the procedure and were not on chronic dialysis. The study design was split up into two parts. The derivation cohort included all PCIs within the first 5 years, so 2012 to 2017, whereas the validation cohort used all the information collected during those 5 years and applied it to the following 3 years, validating the data. And the final number of patients included in each was about 15,000 in the derivation cohort, 6,000 in the validation cohort, so these are really big numbers. Furthermore, the study expanded upon two models. Model 1 used only pre-procedure variables, so before the patient even got onto the table, whereas Module 2 included intra-procedure variables as well. So for example, how much contrast was used and how complex the procedure got. And as you can see here, the Model 1 on the left includes many of the similarities to the original risk score published in 2004. And each risk factor is assigned an integer score. And then additionally, Model 2 includes all these procedural factors such as contrast volume, the procedural bleed, slow flow, and complex anatomy. And comparing what we predict in the orange versus what we actually observed in the purple, one can easily see how successful this risk score is. Almost no comparison. And also, there is not much comparison between Model 1 and Model 2, just a slight difference. But overall, it shows how the pre-procedure steps we take have a major impact, which leads me to my next point. Hydration. This pre-procedural step that sometimes we as nurses don't take seriously enough, when we see the doctor's order for IV hydration, it truly does play a major role in preventing nephropathy. When we use IV hydration, what are we doing? Well, we are increasing the GFR and decreasing the contrast concentration in the filtrate. It isn't always doable, but it is highly recommended to begin IV hydration 3 to 6 hours pre-procedure and then continue it for 12 hours post-procedure, especially in those patients we already know have an elevated creatinine level. At Mount Sinai, we like to bring them in early in the morning for adequate hydration time, and then also for those patients who have a creatinine 1.8 or above. They are automatically admitted as they meet the admission criteria. Lastly, I'll briefly touch on the importance of minimizing contrast delivered. Contrast is one of the few modifiable risk factors we have, so as healthcare professionals, we should really do our parts. And how can we do this? Well, we can monitor how much we give and try not to take extra pictures that are not necessarily needed. We can perform timeouts with the entire team and make them aware of the patient's GFR and creatinine level prior to obtaining access. We can also stage procedures if possible and display any previous angiograms on the monitor for reference. And as Dr. Murphy mentioned before, we can also use IVUS. And in peripheral procedures specifically, we can also use CO2 instead of contrast. The use of carbon dioxide as a contrast agent reduces the volume of iodine contrast required for angiography and reduces the incidence of contrast-induced nephropathy. The use of CO2 as a contrast agent has been documented over the decades but not routinely used. While contrast is the gold standard for imaging, there are a few misconceptions of CO2, such as you might get poor image quality, fear of air embolism, and insufficient filling of the arteries. Because CO2 doesn't mix with the blood, it moves through the blood as an isolated bubble or bubbles, remaining undiluted, which is very different from contrast. So in conclusion, contrast-induced AKI not only can lead to increased hospital stay and costs, but it can also lead to irreversible kidney injury and death. The best way we can prevent this from occurring is to identify high-risk patients using risk scores, hydrate both pre and post-procedure, and minimize the amount of contrast used. Sometimes we get into autopilot mode, especially in emergent situations like a critical limb, but it's also often during these high-risk procedures that we don't stop to think about how much we're truly giving. So hopefully we can all take away something from this lecture and do our part to reduce AKI. Thank you.